everyone. My name is Chadi Alraies. I'm a cardiologist at Detroit Medical Center in Detroit, Michigan. We're coming to you from cardiology updates to tell you about most recent studies. One of the most exciting and most kind of cited and been covered study is DanGer shock. This is a long-awaited trial to evaluate patients with a STEMI and requiring or randomized for MCS versus no MCS. I cannot be more privileged to be with the principal investigator, Dr. Møller, to tell us more about the study. Dr. Møller, thanks for being with us.
Thank you for having me. So DanGer shock is a study in patients with AMI and cardiogenic shock, but it's a small proportion of these patients that we randomized. So we excluded cardiac arrest patients from the study. And when seeing the results, it's important to appreciate that it was quite a small proportion of all AMI shock patients that we actually randomized. But we randomized as soon as we saw shock. It was STEMI, it was high lactate and low blood pressure. Patients were randomized before or during PCI in 85%, and some were randomized up to 12 hours after PCI.
Yeah.
And we saw a survival benefit in the study.
Absolutely. Tell us a little bit about the recruitment and how you started this trial and reasons for expanding to different sites.
Yeah, we thought back in 2011 when we started the study that 10% of AMI patients develop shock. So we thought we would have plenty of patients in Denmark. But with the exclusion criteria, more than 50% is excluded due to cardiac arrest. And then you're left with a smaller proportion, and you exclude patients with right heart failure, with mechanical complication. And then you end up with about 1.52% of a STEMI population. And that made it a very slow recruiting study. So in 2018, we discussed to stop the study, but then we got funding to be able to expand it to Germany and the UK to have more sites. So we were able to finalize it from then. And that's why it took such a long time.
Yeah. So this is, I mean, again, I cannot congratulate you more for this phenomenal, challenging population to treat and also randomization. When you were selecting these sites, were you evaluating the sites based on their experience with the Impella, because it's a 14 French sheath, and Europe is the highest rate of radial access is close to 99%. So how did you select these sites, and what was the main criteria for inclusion?
So these sites were all experienced Impella users by far. And that's how they were selected. So we got funding from Abiomed, the manufacturer of the device, and they helped us identify high volume users. Then there are centers that believe a lot in the technology and do not want to randomize patients, and that's understandable, but that was, some centers were excluded due to that. Some centers participated in ECLS shock, and so for various reasons, some centers did not participate, but these were all experienced centers that were identified.
That's great. So let's go to the study result. Just a highlight of the trial in terms of benefits. When you randomize them to PCI, primary PCI versus primary PCI plus MCS, what was the main highlight and takeaway?
Well, the main highlight was, of course, that we reduced all-cause mortality by 13 absolute percent, which was a hazard ratio of 0.74 with a p-value of 0.04. So it's not a 001 study, but it's only 355 patients in the intention to treat population. So meeting a p-value in such a small trial is quite a strong signal, I think. And that is the take home. The other take home is that it comes at a cost. So we saw more serious adverse events in the Impella treated patients.
Yeah.
So there were more bleeding, more leg ischemia, to our surprise, more renal replacement therapy, and more sepsis. So all serious adverse events. But by the end of the day, we saved patients.
Absolutely. Finally, you said number needed to treat was 8, which is, I think, is very, very significant and low number. One thing I wasn't able to take out from the paper itself is, did you dictate as a designer and main investigator of the trial when to put Impella in, before, during, or after the PCI?
Yeah, so the protocol states that when shock was diagnosed, so when the patient was randomized, the Impella should go in. And in about 55% of the population, this was before PCI. And in the vast majority, the Impella also went in before PCI if randomized there. And we were a little bit ahead of time mandating this back in 2013, where the first patients were randomized. This was before Kapoor's papers on pre-PCI Impella in animals. So,
yeah.
But our philosophy was that what kills the patient is the lack of cardiac output by the minute, and that's what you have to restore, and that was why we mandated this, and I think that is one of the keys to success.
Absolutely.
So this study is not a test of pre versus post PCI Impella. It's a test of immediate PCI when you diagnose shock,
right,
or immediate Impella. Yeah.
So what would be the next step going from now? Is there a follow-up trial? Are you going to follow up these patients for a longer longer follow-up period, or it is a more kind of inclusion or different design for a trial to prove MCS beneficial in STEMI shock?
For us, we are definitely going to follow the patients, and we will be working on this for the next year. I think it's a little bit cumbersome in Germany to get vital status. It's easy in Denmark, where we have good registries. But one of the really surprising things was that the survival curves kept separating beyond 30 days. And that's something we have to look into, whether that is a maintained effect. So yes, that will be one target. And we have a lot of ICU data we will dive into. We will dive into the bleeding complication, the renal failure, to learn more about that. So hopefully during the next year or so, there will be several interesting publications. Hopefully the first will be coming out at TCT in October.
Yeah. So for the audience out there, what is your one-line recommendation to operators who does STEMIs based on the highlight of this trial?
I think you should use it in the patient with pure LV shock. So the non-comatose patient with the hypoperfusion, I do think it carries a survival benefit there.
Well, Dr. Møller, thank you so much for your time. I really appreciate your time, and congratulations for a phenomenal publication and a very tough enrolling and yet successful trial for very challenging patients. For our listeners, for Cardiology Update, this is Chadi Alraies from Detroit Medical Center. Watch us and follow us on social media and the website and our YouTube channel. Thank you again for watching us. And Dr. Møller, thanks again for being with us.
Thank you.